things that, we'll go over some things that you will have to know. We'll do the final then, this is the 4th? Yes. So we'll do the final 2 weeks from today.
Shoot. I think that's when I have to go to Georgia.
Time to get, so is everybody here 2 weeks from today?
No.
Yeah. You can, bro.
I have to go to Georgia then. I planned that
Monday?
around the final.
On Monday.
Yep.
On Monday.
Yeah, I already explained it to her.
Okay. So what we'll do, ladies and gentlemen, is I'll put it on
3 weeks.
Canvas,
Oh, okay.
and I'll give you a week to do it. So I'll put it on Monday
Next week.
afternoon after the class next Monday.
Okay.
And then you can have the rest of that week to do it. Does that make sense to everybody?
Yeah.
Mm-hmm.
So I will email everybody this afternoon so that the 2 people who are here don't think we're going weird when I tell them that there isn't a test next week. Okay?
I think they know.
Okay, so I have forgotten my.
Yeah,
thumbs up, so I
both
will get it.
texted me this morning.
Yeah.
I'm very happy. Definitely my
I'll
day.
be in New York.
We just gotta start arguing more often.
I know, right?
Tests and classes.
I won't be there. No,
No, I won't be here. No, you have to come.
Yeah. I know, right? Can we all FaceTime or something? I think only wait, Molly and Stevie have, or you can FaceTime on WhatsApp, can't you? Why
Yeah.
is my butt cheek burning?
Yeah, fire.
No, that would be my crotch, not my butt cheek.
Travel.
It's the bad shots. I'm kidding. I have to go through a review book you told me to get, so now I have 2 review books. Yeah. I was planning on reading it for myself. Really? You have those? Wow.
So we'll do a review of some of the things. And then we'll,
So we're having a review of this class, right?
pardon?
We're reviewing for the test?
Yes.
Okay. Yeah. Right, Mallory?
What?
You're recording it?
Yep.
Your number 1 job?
My only
Your
job
complete
in this.
existence
Yeah.
here?
The only reason. Huh? I know. There will be like on all the other videos, it's like 1 view, 0 views, and then the review it'll be like 59, and I'm like, Jesus.
I always listen to it. I haven't looked at most.
Yeah.
Back and forth, see it, but it's like a breakdown.
Okay.
You fucking
Is it
kidding
worth
me?
it?
Oh my gosh.
So tell me what you know about percentage depth dose. What do you know about percentage depth dose? If you, most of the answers to this part of the quiz will be in chapter 22 of Washington and Leader. So you can look at them when you get home.
Did you say chapter 22?
Yes.
Okay, thanks.
Okay, so what can you tell me about percentage depth dose? Is there anything you know about percentage depth dose? What is it? And how do you find it? I don't know what that is. Okay. Okay, so we don't want more clear.
At like a certain
Okay,
arrangement.
so when do we use percentage depth dose?
We're trying to find how much radiation is reaching a certain point.
However, there's a certain type of treatment that we use percentage depth dose. There are two types of treatment. There's an SSD technique and there's an SAD technique. Which one do we use percentage depth dose with?
SSD.
Excuse me?
SAD.
No. It is SD. Percentage depth dose is only used for SSD treatments. So can anybody tell me what SSD treatments, what differentiates SSD treatments from SAD treatments?
One is measuring at the surface and one is measuring the central axis.
Measuring what?
The amount of radiation dose.
No. Good thought, but no. So, SSD, let me get my diagram again here. SSD, so this is a patient. Here is the tumor. Okay,
Bitches.
so you have a patient.
Two boobs.
SSD treatment SSD treatment means that the target to the skin, so from here to here is 100 centimeters,
Yes.
right? Fred back so I can see you guys. There we go. So SSD treatment means source to skin distance. So if you're treating a patient with an SSD technique, you're reading 100 to the skin. Okay? So an SAD treatment is source to axis distance, which means that the distance from the source to the axis or the tumor or the isocenter is 100 centimeters. Which one do we normally use in the clinics? SAD. Because if you measure, you're measuring to the isocenter, which is normally the tumor. So when you take an SSD distance on the patient's skin, you're measuring less than 100, 88 or 92 or 75.8 or something. Does that make sense? So the SSD treatment is used with electrons, but the only time that it is used in photon treatment would be extended, what they call extended SSDs. For example, total body radiation, or the whole CNS, so you're treating the whole spine. These are both done at SSD. And occasionally you will do a single field spine. For example, if a patient has a thoracic spine lesion, metastasis, for example, the doctor may ask you to do it at 100 SSD. So anything normally in clinic these days is done at 100 SAD unless otherwise specified. And your percentage depth dose is only used for SSD.
Why?
Why?
Yeah.
Because many moons ago, we used SSD treatments, and this was defined as how to get the dose at a percentage of depth. With SAD, we have other factors like TAR and TMR, which is more usually used for SAD treatments. So it's just a different thing, doing the same thing. Okay, so percentage depth dose. Let me get this up and running here. Oh. Okay.
Oh my god, Mallory, what the fuck?
I just can't help it.
I just had
How
some.
are
just
you
be
guys doing?
Gassy, you know?
I just had some. You know, when I got harassed at the gas station, I just had some. What is it? I don't know. From like a local farm. It's way better than getting the jerky. It's like jerky and cheese, sausage and cheese. I don't know, something like that.
Okay,
But it's from a local
so
farm.
percentage depth dose. Developed for SSD setups, non-isocentric. So the absorbed dose at a depth divided by the absorbed dose at Dmax. Dmax, absorbed dose is how much?
Say that again. I'm sorry.
How much of the dose is actually at Dmax? What percentage of the dose is at Dmax? 100. So what you do is to find the percentage depth dose is you have to have an absorbed dose at depth and an absorbed dose at Dmax. And you can see here that it's dependent on 4 factors. So energy, depth, field size, and SSD. So here is a diagram of it. So you have this point at Dmax and a point at depth. So the ratio of those two is your percentage depth dose. So if you increase the energy, then the percentage depth dose increases. Oh my God. For example, if you have a 6 MV, your depth dose may be 80% at a set depth. If you have an 18 MV with the same field size and everything else, your depth dose at a deeper depth would be 80%. So the energy, if the energy increases, the percentage depth dose increases. Field size increases, the percentage depth dose increases. The SSD increases, the percentage depth dose increases. And that's because of the inverse square law. And the only other one that is the odd person out, as it were, if the percentage depth, if the depth is higher, the percentage depth dose is lower.
Just not if the depth increases.
If the depth increases, percentage depth dose decreases. So if you have a depth here and it's 80%, for example, as you go deeper, the depth gets deeper, the percentage depth dose decreases. So for this one, it might be 70%. Does that make sense? Right? Don't worry, we'll go over this again next week. Once you've read chapter 22 again. Okay, so the depth increases.
Sorry, guys.
What do we expect of the percentage depth dose?
You know how I do.
If we increase the depth, what is the depth dose? What does the percentage depth dose increase to? Or what does it do? It decreases. That's correct. You may, just so that you know, I tend to write percentage depth dose this way because that's the way I was taught. In Europe, they write it that way. But in most places here, you see it as PDD. Got these things. Okay, so that's percentage depth dose. TAR, tissue to air ratio. So this is self-explanatory, really. So you have a ratio of the dose in tissue over the dose in air, or the dose in a phantom. You're obviously not gonna do this in a patient because it needs a ionization chamber to do it. So you're doing it in a phantom, either in a phantom that is what they call solid water, which looks like wood, actually, or in water itself. So the TAR, again, if you raise the TAR, if you raise the energy, the TAR is raised. If you enlarge the field size, the TAR goes up. If you increase the depth, the TAR decreases.
So, for this one and the percentage depth dose, depth is the only thing that's like inversely related.
The rest are, this is the only one that's inversely proportional, and that one's a direct proportional.
We only use this for cobalt 60, 480 and below.
Yeah, well, they sometimes use them for 6MB as well. But this is usually only for non-IMRT patients. But you still have to use these, you still have to know them. I know that you're probably never going to use them, but you have to know them. Because you'll get them, I can guarantee you'll get some questions on your registry on TAR and percentage depth dose. Okay, so here is your TAR. So here is the head of the machine. This is 100 SSD. or excuse me, 100 SAD, this would be. So this is 100 SAD. Here is the air. So this is the ionization chamber, stuck in the middle of the beam with nothing around it except the cover for the ionization chamber. And this is the same place within a phantom. So that's for build-up, okay? So you have the air reading and you have the tissue reading. So free space and then phantom. So those in tissue and those in air. And it's usually, and I repeat, usually less than 1. So it's a decimal. It's 0.753 or 0.896 or something like that. So scatter to air ratio, we don't use this very often, but we'll just go over it a little bit because we don't. So ratio of dose rate with scattering medium to dose rate in air at Dmax. So this is TAR at Dmax. So instead of using the TAR, if the dose was at Dmax, let me go back. So this is dose in tissue and dose in air. So here we're presuming that this is not Dmax for TAR. It's somewhere deeper than Dmax. Dmax would be up here somewhere. So dependent on energy and field size, not on SSD. And depth doesn't come into it because it's always done at Dmax. And again, lower than 8 to 10 MV, which means you could use it for a 6. So there is your dose measured in air, and your dose measured in tissue at Dmax. You notice Dmax is pretty close to the surface there. So here's another one, tissue to phantom, TPR, which is another one. Dose in tissue and dose in phantom is TPR. And here's a TMR, which is dose in tissue and dose in phantom at Dmax. So here is your dose in tissue at Dmax and dose in a phantom at Dmax. So it's the same distance. So dose in the phantom at Dmax, dose in the phantom at depth. Okay, so any device placed in the path of the beam. Anytime you put something in the beam, you alter the dose, right? So what might we add into the beam? MLC doesn't count. So what have you seen? You may not have seen any of it, but what have you seen go into the beam? What could you see going into the beam? Anyone? So, let's put a beam down here. Here's your patient. And here is the accessory holder, is what they normally call it. What could you put in the accessory holder that might alter the beam? Pardon? Blocks, yeah. Actual physical blocks. So that would alter the beam. Not so much the block, but the tray it's on. So you have what is called a tray factor. That alters the beam. Will it make the beam less or more? Would you give the patient less MUs or more MUs if you add a tray? Because you're putting something in the beam which attenuates the beam. Everybody remember what attenuation means? What does attenuation mean? What does attenuation mean? Make what smaller? Not necessarily. What you're doing is, you're putting a beam here, and as soon as it hits the skin, as soon as it hits tissue, it gets less and less and less and less. So you're putting 100% here, and your exit dose is probably something like 20% or less. And that's because the treatment is absorbed as it goes through the body. So if the beam touches anything, even before it hits the body, some of it gets absorbed. So if you put a tray in, you have to give more MU so that you get the correct amount of dose into the patient. So that's the tray factor. There's another factor. My bad writing. That's a wedge factor. What are the wedges? Physical wedges. What do wedges do? Last week we were talking about where we put wedges. Why do we put wedges where they were? They compensate for missing tissue. So remember, we had this, and we had a field going in here and a field going in here. And we put a wedge in here, and we put a wedge in here. These wedges are compensating for the slope, for basically missing tissue. You're trying to make the patient as much of a square as you can. So the wedge compensates for the missing tissue. Therefore, if we didn't have a wedge, this part of the treatment would have a higher dose. than this part of the treatment because there's less tissue. We put a wedge in, and that compensates for that, so you get an even dose. We have to put a wedge in, whether it's electronic or not, whether it's dynamic wedges or physical wedges. We have to put a wedge in. This is non-IMRT. We're talking about, ladies and gentlemen, non-IMRT. IMRT is a completely different system. So if we put a wedge in, the treatment will get absorbed, or the dose will get absorbed by the wedge. And depending on how thick the wedge is, the amount of dose that absorbs will change. So a 15-degree wedge will absorb a little bit. Put a 60-degree wedge in, and it will absorb a lot. So you have a tray factor, you have a wedge factor. That's the two main factors that we would put a patient in.
So is attenuation, absorption,
Yeah.
unintended?
It's the same thing. Some people would use attenuation, some people would use absorption. Usually absorption is usually when the treatment hits the patient. That's absorption. It's absorbed by the tissue. Attenuation tends to be outside of the patient, but you can interchange them. Okay, so if I told you that we put a tray in and without the tray, the patient is getting 100 centigrade. With the tray, the patient is only getting 97 centigrade. What would the tray factor be?
It's 3%.
Then what is the tray factor? The factor is usually 0 point something. 97 and 100.
0.03.
No. 97 and 100 is 0.97.
.97?
That is the tray factor.
Can you repeat that?
Can you write that down and so that we can see it worked out?
Yeah, sure, just give me a sec here. I have it written down here and I just wanna make sure that, oh, yes, okay.
Look at this
So-
picture.
Oh my god.
Shit.
So this is one of the questions, just so that you know. Okay, so
One of the questions on my test.
One of the questions on our test?
maybe I might change it.
No.
I mean, you said it. Jeez.
Okay,
We didn't
so
ask.
you have a tray, okay, with some custom locks on it. Okay, and it's in the beam.
Looks like shit. Can't even see.
So the dose with the tray is 97 centigrade. Everybody knows this is width, right? Okay. And the dose without the tray is 100 centigrade. This is without. What is the tray transmission factor? So what you're doing is you're dividing one into the other, and the answer is 0.97. And as long as I can remember, with a certain type of tray, the tray factor has always been 0.97. It's never changed.
So if the tray dose was 98, it would be 0.98.
Yeah. But with a particular type of tray, it's always been, and it probably always will be unless they change the manufacturers, it's 0.97
Trade transmission
tree transmission
factor.
factor.
So the blocks are not
Gotcha.
calculated in with that?
Not with the tray factor, no. The blocks are done in dosimetry. That gives you a different factor. So this is a tray factor. The same thing would apply with a wedge factor. So if we had a wedge factor, so the dose with the wedge, say a 15-degree wedge, is I'm trying to think what it does. So we'll call it 85. So the dose without a wedge will be 100. So what's the wedge factor? So those with a wedge, a 15-degree wedge is 85. Yeah, 0.85. That's just off the top of my head. I've forgotten the wedge factors. It all depends on what wedge you're using.
Are there units? Is it 0.97 something? Or is it
No, it's just 0.97.
Yeah, it's
This is centigrade, of course.
That's why it's not a difference. I was doing a difference earlier.
the three,
Yeah, but it's its own measuring thing.
Yeah. So it's just the measurements. So. So if I put a wedge in, does it increase or decrease the output of the beam? You're putting something into the beam. Does it increase or decrease? Decrease, yeah. You don't have to think about this one. So anytime something is put in to the beam, it must be corrected for it. Put a wedge in, there's a wedge correction factor. You put a tray in, there's a tray correction factor. You put a compensator in, there's a compensator factor. We don't use compensator factor any time. So, if I put, if the plan calls for a 45-degree wedge, and the therapist leaves it out, what does that do to the dose? Does it increase or decrease the dose? You're using the calculation for a wedge factor, but for some reason, the therapist leaves it out and nobody else notices. So you get more dose, or does the patient get more dose or less dose? You leave the wedge out more. especially if it's a 45-degree wedge, it can give a nasty overdose. Same with a 30-degree wedge. Does it, here's another one. So we know that the dose is increased if we leave a wedge out. What does it do to the isodose distribution? You're looking at a plan, and there should be a wedge in there. And you leave it out. Does the fact that you leave it out alter the distribution of the dose? Yes. And does that be why? If you have a wedge in, then the dose is altered because the wedge has gone in. The actual distribution of the dose has been altered. You forget to put that wedge in, and all of the dose is shifted. The actual distribution of the dose is shifted. So you may be treating one part of the treatment with a higher dose than the other part because you left the wedge out. For example, this. If we left this wedge out, oops. So if we lift this wedge out, then this part of the treatment would get a much higher dose than it was supposed to. And this part of the treatment would get a lower dose. So your distribution of the dose in the tumor here would be altered. Does that make sense? Okay. Wonderful. Okay. Okay. So, everybody remember what the separation means? Can somebody tell me, please, what the separation is of a patient? Yeah.
Yes.
The distance between 2 points, the entrance and exit points, basically. So you can have an AP separation, APPA separation, and a lateral one. So it's the difference between the entrance point of the patient and the exit point of the patient. So if the patient if the patient's depth, the midpoint of the patient, was 91 centimeters with an SAD treatment, what is the SSD at the AP skin?
What is the SAD again? No, what did you?
The SAD is 100. The SAD is 100, the SSD on skin is 91. What's the depth to the isocenter? 9, okay? So, again, PA, the SSD, excuse me, is 89. What's the depth? Okay. So then what is the separation of the patient? Yep. So you have an AP depth and a PA depth. You're reading 91 to the AP, which means the depth is 9. You're reading 89 from the back, which means the depth is 11. You add them both together, you get 20 separation. Skinny little person.
Yeah.
Really skinny. Does that make sense to anybody or everybody? What that is? Okay?
Didn't we factor in the table fitness at some point when we were upstairs?
Yes, we did.
It is.
Yes, we did. But for this particular exercise, we're just doing it with keeping it simple. Keeping it simple. Yeah. There are some tables that have openings. So you don't have the solid table, you have an opening so you can actually read what is on the skin. But for this example, the table doesn't exist. Okay. Okay. Equivalent squares. You might need a calculator and a piece of paper or a piece of paper. Equivalent square of a 20 by 10 centimeter rectangle. What's the equivalent square? Say again?
13.3 feet.
13.333333. Yeah. I need everybody to make sure they know what they're. So does anybody not get 13.3? Okay.
I did it really fast, not writing anything down, so I hope that's, I could have had figured it, I'm sure.
Okay, we'll give everybody a couple of minutes. So is anybody not, oh, we're still working, okay.
You have the same finally.
Okay. So how did you do it? Did you use the
I did 4.
Sterling factor?
I don't remember the names of them. I did 4 times
Yeah.
area time and perimeter.
Yeah, that's the Sterling factor.
Sterling.
That's just the one I remember, so that's
Okay,
the one I did.
whatever works. Whatever works. I prefer to use another method, but whatever works for you. So what I use is the width times length times 2, dividing by width plus length. That works for me. I find that easier than the area plus the perimeter, or area and perimeter. So-
Say that again, what do you use?
Oh, width times length times 2. I'll write it down for you. I'll write it on the board.
I like that better.
So you have width times length times 2 over width plus length. So you have,
It's written out a little easier, so you don't have to remember.
Yeah. so if you have 20 by 10 times 2 and 20 plus 10. So whatever way works for you. And sometimes if they're asking this, they may, and I repeat may, give you a table. Use the table. I think there's a table. Oh no, it's in the other one I was looking at, sorry. Okay, so another one. You remember us doing weighting? Yeah? Okay. So this one again, you may or may not need your calculator for. So I will read it to you. And I may just change the figures around for the calculations so that you don't have that same one. Okay. A physician prescribes the APPA fields to be weighted 3-to-1 for the posterior fields. You paying attention?
I'm listening.
Yeah, okay. How much dose is coming from the AP and the PA if the total dose prescribed is 200? So I want a dose from the AP and a dose from the PA. 3-to-1 weighting for the PA, and the total dose is 200.
So it's 3-to-1.
Yep.
The PA is the 3 or the 1? 3.
3-to-1 for the PA field. So the PA is 3.
So 150.
And I want them both. I want AP and PA.
150 and 50.
Which one's which?
So then 150 is the PA. And
50 for the AP.
Did everybody get that? Or is somebody still working on it? You're still working on it, you didn't get it?
got it.
You got it. So you got 150 and 50, PA, AP. How did you do it?
I do it. Okay, so if it's 3-to-1, that's 4. So divide 200 by 4, and then whatever that is, times 3 for the 3, times 1 for the 1.
So you've got 200, you've got 4, 3-to-1. You divide 200 by 4, which gives you 50. Right? So 50 is your AP because that's 1. You multiply by 3, 150 gives you the PA. Make sense? Everybody understand that? That's an easy one.
How similar are the exam questions to this?
Oh my god.
Like, is it
What, you mean the test that we're gonna have in
weighted
2
3-to-1,
weeks?
or is it gonna be, yes?
It won't be much different to that. I'm not gonna give you 3.5 to 2.5, right, so like
That's
that.
all.
Somebody tell me what Dmax is. What's the definition of Dmax?
Maximum dose.
That's at which 100% of the dose is distributed.
She doesn't know the answer.
Okay. 100% of the dose is distributed.
That means that
Okay. So is there another name for it? Another name for Dmax?
absorbed dose.
It's something, you may have heard, I think I mentioned, or it was mentioned last week or the week before. It's the depth of maximum equilibrium. But it's usually called Dmax. So here, just so that you get this clarified, so the tray transmission factor defines how much of the radiation is transmitted through a block tray. Numerical measurement by physics, so that's where the tray factor comes from. They do measurements. So when you use a transmission factor when custom blocks are mounted on a plastic or perspex tray. Examples of transmission factor, 0.97, which we mentioned there, means that 97% of the beam is transmitted. So you're right in 3%, because 3% is absorbed, but 97% is transmitted through. So your tray factor is 0.97. And the wedge factor, wedge transmission factors, basically how much radiation is transmitted through a physical wedge. So the physical wedge goes in, and there's some of the radiation absorbed. So, what is absorbed dose? Ignore these. What is absorbed dose?
How much of the dose is absorbed?
Yeah.
Absorbed dose is the amount of dose which is applied to the tissue. Once it gets into tissue, it's called absorbed dose. Okay. So absorbed dose is measured in centigrade. So if I asked you which of the following phrases does not apply to absorbed dose? Energy deposited at a point, measured in centigrade, can measure absorbed dose using ionization chambers, or measured in air. Which one does not apply to absorbed dose?
Measured in air.
Measured in air, because you're measuring it in tissue. So that is what I was going to give you for a test next week, or the week after. But I'm gonna add some things. Okay. Keep it fresh. Okay,
Why?
SSD calculation step. No,
Why?
no. Okay. Given dose.
That point, accurate.
Oh yeah, there was one other thing. Maynard factor. Do you remember Maynard factor?
I do. I don't remember.
We went over this when we did physics. first semester.
Excuse me.
First semester.
Ignore this.
Thank you.
Ignore this. We'll go over that a little bit more later. Maynard factor is used to convert percentage depth dose at a reference issue to the percentage depth dose at a non-reference distance. This would occur at extended distance setups.
Only for extended distance?
Only for extended distance SSD setups. So if we are doing a total body, or we're doing a whole spine, that you have to use extended distance because you can't get the field size in with a 40 or 40 field size, then you would have to use a Maynard factor. And there's actually a very good video, and it's a cartoon type character. Her name is Sadie Ray Dish. Sadie Ray and then Ish. And she does a few very good videos. One is on the Maynard factor. One is on depth doses. One is on calculations. So we'll do this. So, calculations. We're going to start on that now, because you need to know this. You determine the equivalent square for the collimator setting. So a 20 by 10, you would look up on all of your tables. 15.3. Determine the effective field size and determine the scatter factor and tissue absorption factor. Determine the appropriate tissue absorption factor on the appropriate machine. Determine the prescribed dose. Look up factors using appropriate data tables. And then use appropriate equation.
What was the SP on number 2?
Scatter factors. So here is your prescribed dose. This is non-isocentric. This is for SSD counts, which you very rarely will see. Okay. So all of these factors, your percentage depth dose is usually done as percentage. So 97%, for example. To get that to a decimal, which you need for the calculation, you divide it by 100. So 97 becomes 0.97. So, TPR is tissue phantom ratio. So what you do is you have all the factors, scatter factors, the TAR, the TMR, all of that stuff. Didn't mean to do that. And any factor that is given to you, you put, the rule of thumb is you put the dose on the top and all the other factors down below. So TAR, your tray factor, your wedge factor, your centigrade per centigrade per MU factor, And you divide all of these into that, and you get the MU.
It sounds simplified, but in
It
the
is
end,
simplified.
are they gonna throw something extra in there to try and throw us off? Cause it's easy to say everything else goes in the bottom.
Yeah,
So, but how
everything
do you
else
know-
goes in the bottom.
So if they give us something that really doesn't affect,
What they'll do
it's
is
just the
they'll
garbage
give you,
info.
they'll give you all the factors that you need. They won't throw something in as garbage.
Okay.
They will not throw something in. They'll do something like, there is a tray factor, there is a wedge factor, there is a centigrade per MU factor, there is a distance factor, there is a field size type factor. All the stuff that you need will be there,
But nothing extra. You know,
nothing extra.
Okay.
No, they
'cause
won't
I know-
throw you in garbage.
Okay, but the walls are so many centimeters thick.
No.
What is the dose? And then you're like,
No. No.
Okay.
The stuff that they'll give you, and they may give you tables, but they're more than likely just give you the factors that you need. The only time that they will probably not give you a table is the equivalent square, and you should be able to work that out on your own. They're not gonna ask you to work out a TAR or a TMR. They may ask you to work out what the percentage depth dose is. So, I have one here. So we're looking at, and I'll tell you how to do it. Calculate the percentage depth dose of depth D if the dose at D max is 250 and the dose at D is 231. So, let's work that out. Let's take this step. Okay, so you have, sorry. So you have those D max is 250 centigrade. And D equals 231. So you're looking for the percentage depth dose equals. How are you going to do that?
231 divided by 250.
So D max is 100, right? D max is 100? Yeah? Okay. Cross multiplication, ladies and gentlemen. So you're actually working with 231 divided by 250. What does that mean?
0.924.
Multiply by 100,
92.4%.
there you go. Equals 0.924 times 100, 92.4%. That's your percentage depth dose. Easy peasy. Cross multiplication.
Can you read that out to me again? So I know that the D-max is
Okay,
250.
calculate the percentage depth dose of D, depth D. If the dose is, the dose at D max is 250 centigrade, and the dose at D is 231. So you calculate the
Dose, new
your percentage dose, percentage depth dose. So you're looking for D, you're looking for the dose at D, or the percentage at D. which turns out to be 92.4. Okay, so does that work? Okay, let's take a break, guys. So we'll see you back here by this clock. Because head first could mean anything. Okay. Head first in towards gantry. Sorry, somebody said mask.
Mask.
Okay, what kind of mask?
Mask.
Okay,
Bite black.
pardon?
A bite black.
Sometimes you don't
Doesn't
always need a bite lock. So do you want to use the small mask or the big mask?
Depends on the size of my eyes.
Okay then, what type of treatment site might you use a large mask for? Specifically, what site or sites?
The one.
Pardon? Cervical? You mean the spine?
No,
That's not counted head and neck.
it's counted skeletal.
That's spine.
Skeletal.
From there down is spine. So neck would be what? What sites are in the neck? Thyroid?
Esophageus.
Esophageus? Esophageus?
Oh
I'm just trying to be like you.
Esophageal? Maybe, but that's not counting head and neck either.
Oh my god.
Okay, what about
Tiny.
larynx?
We have one right now, but we don't use the one,
The larynx.
What?
for true vocal cords.
The true vocal cord. Okay.
I don't know if it's considered long, it's like a weird, it's not like the ones we use upstairs,
For example,
Okay,
that
so-
one.
not that long, it kind of dips a little bit, but
Okay.
it's under the shoulders, it doesn't
Yeah,
pull the
okay,
shoulders down.
but it covers the larynx, right?
Yeah.
What?
Yeah, like that one,
over there.
that's the one they're using.
This one, this
That
little.
brownish.
Yeah, but, okay, that's fine. So that's not what I counted a large mask, but yeah, that's fine. So what if they don't have large masks?
Wow.
So you have to use a short mask.
Well, that
And
would
you're
make sense.
treating
We would never not
larynx.
have one.
Everybody's pronouncing larynx the correct way?
Larynx.
No,
That gets on my nerves.
it is on my nerves as well, so.
Don't call
What's the wrong way?
I can't
Morgan,
even say
don't
it.
call
it.
it that.
Larynx. That is incorrect, and you will be pulled up by anybody and everybody if you say that.
I've
Okay?
literally never heard anybody
Anyway,
say that.
I know, I've never heard anybody
She's so
say that
dramatic.
either.
Don't do that.
My dad says it.
People say skeletal weird too.
Yeah.
He says everything.
Jesus Christ.
Does he say prostrate as well?
Oh.
I have heard that.
He puts the
Yeah,
emphasis on
I used to have patients who say, and I'm getting my prostrate treated, and I'm thinking, oh,
What did he say?
well, they're all farmers, so they don't know any better, but anyway. So if we were treating, back to what we're doing, if we were treating a larynx and we did not have any large masks, how could we keep the patient's shoulders down? Obviously, you don't want them to do this, because you're shoulder pulls, yeah. Has anybody seen the shoulder pulls? Has everybody seen the shoulder pulls?
Yes.
Yeah, I used them twice this week.
No.
Ask them to show it to you.
You
You
put
should
you
have
put
one
it
there.
you wrap it around their wrist.
Yeah,
You hold it. Well, not you, the patient, and then it straps
Yeah.
right underneath. You
On
pull
their
them.
feet.
yeah,
it straps
basically
right
what
underneath
you
their feet.
do,
I didn't see it until
yeah,
the
what you do
Proton
is you
Center.
have the sort of like soft
In
cups
Gainesville, they're
They
different.
have
The
there.
depressors in Gainesville are the same thing.
They're the same thing, but I like them
Put it
better.
around their feet with their knees bent, and then you ask them to straighten their knees, and that pushes the shoulders down. The problem with that, anybody tell me the problem with that, and then they put a mask on you. On the patient. Can anybody tell me a problem with that? How do you what do you tell the patient if they need help? What do they do?
Lift their knees.
Raise your legs.
Pardon?
Raise your legs.
Raise their legs?
If they need what?
Wave their,
Hand.
wave their hand usually.
Wave their hand or call out. Now, with a mask on, you can't really do that, can you?
Oh, bite blocking.
And with the shoulder pulls on, you can't do anything. Because you can't really you could raise your knees, but that would
That's what we always tell them.
raise their knees.
Cause I mean, what else, I mean, there's not very many options.
No, there isn't. That's it.
And they can release it, like it would loosen
You
their
raise your
arms if they
knees.
raise their knees.
Yeah.
Stops
Yeah.
the restriction.
But anyway, so that's all very well. So if you had two patients, one who had a palliative brain met and one who had, or we were treating IMRT brain, would we use the same masks on both of them?
What are the two?
Maybe.
Pardon?
What two did you say?
One who had a brain met, a brain metastasis, and the other one, a primary brain, and we were treating IMRT. Would we use the same type of mask on both of them?
I think so.
You might. Gainesville pretty much used all of the same masks.
Pardon?
Well, my SRS
Okay,
mask
let me
is
show you
different
something.
from my.
Yeah, but that's not SRS.
Okay, so, excuse me, ladies.
It wasn't. That's very
There's two masks. What's the difference?
One's more flexible.
One is very flexible. Ignore this, I keep cutting this off, but anyway. This is very flexible. This would be used probably for a brain metastasis. All you really want to do is keep the patient in the same position. You're treating the whole brain, so you have to watch the eyes, but you can't really miss. So you keep this. So this is a reinforced mask. This is what is sometimes called an IMRT mask. It is reinforced. You see how it's reinforced here. So this is a little more sturdy, and the patient can't move quite as much. So this is probably what we would use for a primary brain IMRT. Okay? Makes sense? Because you're treating a small area. You're not doing SRS or SBRT on these patients, but you're still treating a relatively small area. So you want the patient to stay as immobile as possible. And with these ones, you would not cut out the area around the eyes, if the patient could manage that. And you certainly wouldn't cut out the mouth. Here, you could probably, 9 times out of 10, you cut out the eyes, cut out the area around the eyes. Be careful when you say that, by the way. You hear what I just said, cut out the eyes? The patient's sitting there, lying there going, "Ah." So cut out the area around the eyes. And maybe a little bit on the mouth so they can feel as if they're breathing okay. That's the two different masks that you might use. So, let's go ahead and see what we can do with the head and neck. So somebody said bite block. Why would we need to use a bite block? Do you need a bite block for everything? No. So, okay, so what diagnosis or what treatment area might you use a bite block for?
Down here. Yeah.
It's a big area.
Tonsil.
Anywhere down there.
Tonsil,
Oropharynx.
okay. Oropharynx.
That's not a big area.
Anything else? What about tongue? Base of tongue. Now, why would you use a bite block on these different diagnoses? What does the bite block do?
Keeps the jaw.
Keeps the mandible in a specific spot, keeps the tongue depressed.
Okay, keeps the area in the same place. So does it do anything? If you don't use a manual, what type of bite block do you use in your clinics? Have you seen? Are they manufactured bite blocks from companies, or are they something that's homemade?
Homemade.
So what do they use?
Oh wait. So we get it from a place and then we make it like in a hot water
so
bath.
it's
and then
from a manufacturer, it's not made in-house.
Oh.
Okay. So anybody use bite blocks that are fashioned by the therapists themselves? No? Okay. So what does the bite block do to the tongue? Why would you want to depress the tongue?
The tongue is very malleable,
Uh-huh.
easy to move.
Okay, but why would you want to depress it?
You want to keep it out of the way?
Keep it out of the way, or maybe
Get it in the way.
keep it in the way, yeah. So you're either putting the bite block, as far as the tongue's concerned, you're putting the bite block in either to take the tongue out of the field, in this case it would be treating up here, or you're putting the tongue into the field, which means we'd be treating down here somewhere. Okay, make sense? Okay, so let's see what we got. So anterior tongue. What part of, oh, it's just told me last, okay. So what part of the tongue is the anterior portion, if you didn't see it already? So if I said anterior tongue, what portion of the tongue might that be?
the part in the back of your throat.
The part of the tongue that moves.
Oh.
So it goes all the way back. Oh, probably, sorry. I have a really bad, really good, depending on which way you look at it, gag reflex. So it goes all.
I don't have a gag reflex at
any part of
all.
the tongue that you
I wonder
can
why.
move is the anterior tongue. Okay. So the anterior tongue. Small tumors on the anterior 2/3 of the tongue are usually resected.
You know what helps you with your gag reflex?
What?
Practice.
You get a lot of that, don't you?
Just like you
Try
gotta
that,
gag
doesn't
yourself.
work, doesn't work. Okay. Okay, let's go back to the clinical side this time, please. Okay,
Try
so
that.
if you have a small tumor on the tongue and you resect it, you're taking part of the tongue away. So what do you call a removal?
There's
of
masked
the tongue?
individuals looking into our room. A few of them. Oh, Ash is leaving.
Can I help you? Yeah, it'll will. Okay. Okay, thank you.
What do they want?
It's part of the board. They're having a meeting, next door, and they're having a little meeting in here, on the Tuesday, so. Anyway, so,
Are we supposed to wear masks?
so what is the name given to removal of the tongue?
Glossectomy.
Pardon? Glossectomy. That's a total. Total glossectomy would be the total removal of the tongue. Hemiglossectomy would be removal of part of the tongue. So if you're lucky, patient only has half his tongue removed, and he can still talk. If you have all the tongue removed, it's extremely difficult for the patient to talk. So radiation therapy is used in patients who are medically inoperable as far as the tongue goes. So if you have a patient who is a bad operative risk, somebody who, so what would make, just for the heck of it, what would make someone a bad risk for surgery?
Anesthesia reaction?
Anesthesia reactions, okay. You mean, yeah, okay.
No, you could be like,
General anesthesia, you mean?
Yeah.
Okay. General anesthesia reaction, okay, and else?
Immunocompromised.
That wouldn't necessarily mean that we're a high operative risk.
blood
But
disorder.
yeah, that's one thing.
Blood disorder.
Again, that wouldn't necessarily mean that we're
Maybe
an ultra
Heart
high.
issues.
Age?
maybe, yeah.
Yeah.
If they're really old, sometimes they don't do surgery.
Define really old.
Like 70 years old.
I mean, like.
How old are you? Sorry. Just kidding.
I think like,
So old, you don't really
I'm not
want
even
to
gonna
put
say
one in your scared they might not come back.
Well, yeah. If for example, the lungs were compromised, if they had a chest problem or lung problem where they might not survive the surgery, that would make them a high risk. Okay, so post-op radiation to the site and cervical lymph nodes are used because positive margins, extensive primary tumor with bone or skin invasion. So if the patient has extensive primary tumor with bone and skin invasion, they probably
tastes
wouldn't do
so bad.
surgery on them.
I can already taste it. And I haven't even had it yet.
And multiple lymph nodes, they may do surgery, however. Radiation therapy used for unresectable tumors because of better cosmetic and functional results. So if the surgeons went in to remove part of the tongue and they had lots of lymph nodes, they would have to go and remove those too. That's called a node dissection. And sometimes if they remove a lot of nodes, it can alter the anatomy of the patient. So you can have a patient who has nodes on this side and they remove them and the patient looks as if he's got a caved in neck. Really nasty looking. So we sometimes get the patients who, in this case, extensive primary tumor with bone and skin invasion are multiple lymph nodes. We would treat those and would have a better functional result and a better cosmetic result. So we wouldn't deflate their neck like the surgeons do, and believe you me, it's not pretty when you have a surgical resection. So lymphatic drainage from the tongue. Where does the lymphatic drainage of the tongue go? Or where does the lymphatic drainage of the tongue end up? Usually lymphatic nodes. Usually the cervical nodes, eventually. And then down to the supraclavicular nodes. So, 4,500 in 4.5 weeks, then reduced to off cord to 6,000. This is non-IMRT. All of these are non-IMRT. So 4,500 in 4.5 weeks, then reduced the off cord to 6,000, and then a boost to the primary area up to about 7,500. That's a heck of a lot of dose. And remember, some of these patients are getting radiosensitizers. Anybody remember what radiosensitizers are?
Something that makes them more sensitive to radiation.
Say again?
Something that makes them more sensitive to the radiation.
The tissue's more sensitive to radiation.
Yeah.
So the problem with that is it also enhances the reaction to the treatment. So not only are you giving 6,500 to 7,500, which gives you quite a bit of skin reaction inside and out, then you're going to give them radiosensitizers all the way through treatment, which enhances the reaction. So they're going to be extra miserable if they're going to be miserable anyway with this type of treatment. All head and neck patients are miserable. Have you noticed that?
Mm-hmm.
They're not happy campers. And then you add, excuse me, this radiosensitizer on top of that, and they're really miserable. So, this is the area that we would treat. Here's your depressor.
Jesus Christ.
Bless you.
Thank you.
Here's your tongue depressor. So in this case, you're pushing the tongue down. Here's your tumor. And there's some nodes back here. So you put your tongue depressor in. This is the area that we would be treating, because there's only one little node. If there was a couple of nodes down here, you may expand this a little bit. So you notice that we're going out here, we're taking in all of the tongue, and we're going out here, covering the cord. So what would we do with the cord? We have to reduce the cord, reduce the area that is treated. At what dose?
4,500.
4,500. That's why we say 4,500 in 4.5 weeks, then reduce the off cord to 6,000. So what we would do is we would run a line through, we'd put an extra shielding in here, so that this part was all shielded for part 2 and part 3. So if we don't have a fancy tongue depressor, or that area, what could we use? If we don't have a mouth bite, a fancy mouth bite coming from the manufacturer, the doctor's cheap, he doesn't want to do that. What could we use? Just, if it's a case of just pushing the tongue down out of the way, what could we use? You know these wooden tongue depressors that the doctor just pushes your tongue down to look down your throat?
That's what I was.
You get half a dozen of those, you take them all together, and that's a good tongue depressor. So you put that in your mouth. It's for the one patient. Yeah. And you can put a rubber glove around it so that it doesn't taste like wood.
Yeah, that would actually.
The other thing that we used to use quite a bit, for, especially for palliative patients, corks, like wine corks. Put it in. Wonderful. Easy peasy. And we had a dog who used to bring in lots of wine corks. She drank a lot of wine. That's it. Well, she and her husband drank a lot of wine.
I'm sure.
So every time they went out for dinner and they got a bottle of wine, she would ask the waiter for the wine cork. And they must have thought she was nuts, but they always gave it to her. So she had this supply in her office. So anyway, so it doesn't have to be fancy. So that's the tongue. Floor and mouth. Small tumor can be treated with an implant or external beam therapy as a boost. Not well confined, external beam can be given to 7,000 in 7.5 weeks. Mandible should be spared if at all possible. Small sections may be surgically removed, small lesions may be surgically removed. This should be followed by treatment giving about 6,000 in 6 weeks. Regional lymph nodes must be included in the treatment and see the images. So this is, I'm going to put the lights off for a minute, or at least one set of lights. So, this is floor mouth. The mouth is open, you can see that, right? The mouth is open. Here is the tumor volume, here. So we're treating all of this to begin with. So there's the upper border, there's the lower border, there's the outside here. So what we're doing is we're shielding this part, we're shielding down here, we're going along, we're going up here, and we're shielding this part. So this is part one, the large fields. Unfortunately, because of where the tumor volume is, you cannot save the mandible. There's your center of your field. So this would be 4,500 because your spinal cord is in the treatment area. So then we used to do, this is non-IMRT, we would do off cord. So in that case, you would do this part here, here, and then here. So all of that would be treated to about 6,000. Then the tumor volume here, so this little area would be treated to approximately 7,000. And then the lymph nodes could be treated with an electron boost if necessary. Meanwhile, the back of this is treated with an electron boost because you're shielding the spinal cord, but there's nodes that run along the spinal cord that you have to treat. So in this case, it would be electrons. And this is for the mouth. Any questions on that?
dotted arch on the left, the top left,
This or this,
this, yeah, there.
there, that is from the beginning. So this is the base of the skull. So you wanna shield that. So this part is shielded, this part is shielded from the beginning. Both of these are shielded from the beginning.
Is the dotted part of the electron boost?
This part,
Yeah, the
or this
arch,
part,
the arch to the left,
this part,
yes.
no. This is shielded from the beginning. So this is all shielded all the time. This part, however, is shielded off because the cord from there back is shielded from the photons, but you can treat with electrons. Because electrons, remember, don't go in very far, right? And then you have this little piece here that you can also treat with electrons if necessary. And then this is photons here. So all of this is treated to 4,500. And then after 4,500, this is the area that we're treating. This dotted line. This is the area we're treating. This part is no longer being treated. This part is no longer being treated. So you've only got this part. Just this part. So that would work to about 6,000. And then this little part, maybe to 7, and this little part to 7. And then, because we know that the nodes might go down to the supraclavicular fossa, we want to treat the supraclavicular fossa. Supraclavicular fossa, infraclavicular fossa. So here is the clavicles, here. This is as much as we can shield of the apex of the lung. Obviously the apex of the lung comes up here, but we're treating,
That's my asshole, remember?
we
That
need
shit
to
must have
treat
been
this area because of the nodes, here and here, here and here. So we're treating all of this. This is the C spine, so we need to shield that. And this is the area we're treating. So the lip. This is part of the head and neck. However, most lip cancers are treated with either superficial or electrons. They're treated like skin. So you can be treated with electrons using lead cutouts to protect surrounding areas. Intraoral shield may be used to protect the underlying mucosa. If we're treating here, we need to put some shielding in here to protect the rest of the lip and the gums. Bolus, depending on what we're treating. The superficial or orthovoltage, we don't need bolus because where's the max for superficial or orthovoltage? Superficial or orthovoltage, generally give me a max for either or. Zero on skin. Emax for superficial or orthovoltage is on the skin, same as electrons. Okay. So small lesions, 45 to 55,000 in 3 weeks. Larger lesions, 65 to 7,000. And you could use an implant as well. Lymph nodes are usually treated if the primary lesion is large. If you're treating a small area on the lip, you probably will not have to treat the lymph nodes because the lymph nodes are not involved. However, if it's a large lesion, you should treat it. So here is a lesion on the lip. Skin lesion. See it? This is inside the lip. Over here somewhere. Looks evil, doesn't it?
Teeth look bad.
Huh?
Those teeth look bad.
Yeah. So that being said, let's go back here. What is the cause, the normal cause of lip cancer? See, chewing tobacco? Actually, no.
Alcohol.
No.
Smoking.
Pardon?
Smoking.
No. Well, tobacco use, yes, not smoke. Sorry?
The pipe?
The pipe. Thank you. The pipe. And who's ever seen anybody smoking a pipe? Has anybody ever seen somebody smoking a pipe?
Years ago.
So, I had an uncle who smoked a pipe. And he literally would not take that damn pipe out of his mouth. He would, unless my aunt actually took it out for him to eat, but he'd talk with it, he'd drink with it, he would talk with it, everything he did. He would even eat with it if my aunt allowed it.
Doesn't make any sense.
But they don't take the pipes out of the mouth. And the pipe stem gets warm. So it irritates the lip. So a lot of these lip lesions are to one side. You can see that this is slightly to the one side of this. So if he had the pipe hanging out of this side of the mouth, then the lip lesion would probably be here. If it was on the other side, obviously. So that's why they're usually one-sided. And that's the most common predisposition, shall we say, for lip cancer, is smoking a pipe. We don't often see them anymore because not a lot of people smoke pipes anymore. But a lot of people still occasionally smoke cigars. And a lot of the times, people don't take cigars out of their mouths either. Not as much as the pipes, but yeah. Just so that you know, for smokeless or for chewing tobacco, the lesions are usually buccal mucosa, cheek. Because where does the smoking tobacco, the chewing tobacco sit when you're not, it's in here, right? Am I right? Yes? No? Maybe? Don't know?
I don't think a lot.
Okay, no. So most people who are using chewing tobacco will have them sit in their cheek. Here. So they'll get a lesion in their cheek, in the buccal mucosa. So we would treat that with either electrons or photons, or if you have a superficial or deep X-ray machine, you could use that. But most people don't have that type of thing these days. So electrons. So how do you get an electron cone? What's the smallest size of electron cone we have? 4 by 4, some places is a 6 by 6. Some places have a six circle cone. So what you would have to do is you would have to do a cutout. Do a a cutout with cerebendin to match this size. Or actually a little bit bigger, because you want to do a little bit of a larger circle. So how do you get that patient to lie like that without obviously somebody holding the lip open? Tape it open. Okay. What we used to do is somebody would hold it like this lady's holding this, and we'd put the cone in, and the cone goes right onto the skin, and that holds it. As long as the patient's compliant. If the patient's not compliant, then you have to tape it. There's no two ways about it. And to tape that is a little bit difficult because, why? Why is it a little bit difficult to tape that? Wet. It's very wet. And you have a patient open, with their mouth open, what's happening? Saliva. Lots of saliva, because you have to have the mouth open and they may swallow, but most of the time they just dribble out. So, yeah. It's an easy treatment to do as long as you can get the patient in position.
She already ruined it.
Correctly. But you're right, it's teeth open the beauty of it. So would we cover the teeth or the gums, actually, not the teeth, but the gums? Would we shield the gums? If we were just treating, this area here, then you might want to put a piece of lead, covered obviously, over the top of the gums to make it patient feel better. But really, with electrons, you don't really need it. The problem is you have to make sure the patient's not going to swallow whatever you put in their mouth. Right? So, questions on that? Okay, so larynx, glottis. So consists of the glottis, or the larynx consists of the glottis, supraglottis, and subglottis. The glottis does not have any lymphatics, remember that, that's a question that comes up a lot. Do we treat lymphatic drainage when we're treating the glottis? That's a question that comes up a lot. And the answer to that is no, because the glottis does not have any lymphatic drainage. The incidence of a lymph node involvement in a T1 lesion, which is a glottic lesion, is 0 to 5%, so very, very rare. Early stage treated with radiation alone. Almost all larynx patients who are early stage are treated by radiation alone. It works. It's an easy treatment. It's one of the few treatments that these days is still treated with non-IMRT because it's so easy to do. You treat small fields, opposed pair, approximately 5 by 5 or about 6 by 6. Due to the shape of the patient's neck, wedges are used, usually 15. Fields are centered over the vocal cords and a splash over the anterior skin to prevent underdosage of the anterior commissure. Okay, Where is the anterior commissure? Where is that? Is that TNM book? No, okay. There's a little book that is bright red and it's TNM.
What's my Dollar Tree book?
Huh?
That's my Dollar Tree notebook.
Oh, okay. So to do, let me just put this back on again. Cool. Sorry. That's way up. Okay, so. Let's, so. Oh.
More stylish than me.
I know.
So larynx.
Dr. Lee, she
Or
got
neck,
$60
I should
shoes
say.
to match my outfit. She was like, no, I want my rain boots. My $5
Sure.
boots from Amazon.
Is here.
Don't I look so different?
And then we
You
treat
look a kid.
2 fields.
This is gonna be your kid.
Two fields. And because of the slope here, we put wedges in. Now you could do these with physical wedges, or you can do them with dynamic wedges, it really doesn't matter. So you have 2 laterals, right and left lateral, and you'd have the field that comes across here. So that is the flash. Remember the flash for the breast? Same thing. Goes across the neck here. So the idea is that you don't want to underdose any of this area here. So you have a flash. Make sure there's a flash at the top.
So is that the anterior commissure, the top hump?
Yeah. The anterior commissure is right here. And the dose, depending on what we're doing, it can range anything from 6,005 to about 7,005, depending on what the physicians want to do. These are early stage patients. What's the most common when we were doing head and neck and we were doing larynx last semester, what's the most common thing that patients complained of? Sorry. Sore throat? Anybody else? Sore throat, anything else? Difficulty swallowing? Hoarseness. Hoarseness is usually the first one. The problem is a lot of these people drink and smoke. So a lot of it could be a smoker's cough. Or if you know of a smoker and you know how hoarse sometimes their voice gets. So here is your glottis. So this is the area we're training. There's your spinal cord, so we don't touch the spinal cord. And this is just with the wedge here. And there's your edge of your patient here. So this is the external commissure. So there's the mandible, there's the skull.
Where's the hyoid bone in respect to this? Below?
It's up here. So supraglottic, obviously higher than the glottis. These poorer prognosis because they usually involve lymph nodes. Depending on the extent of the disease, the treatment can be either surgery or radiation. Radiation therapy is considered the initial treatment for early tumors. More advanced tumors combine either pre or post-op radiation therapy. And sometimes they can be given BID. So what's the normal dose for a tumor or a head and neck patient? Daily dose. 180 to 200, depending on what it. So here we're giving BID 120 per fraction to a total of about 7,500. And part of the surgery is a tracheostomy.
So if they're BID, that person's getting 240 centigrade a day?
Yes. That's correct. But you do it in fractions rather than days. So it's how you would specify that is not 240 a day. You would do 120 BID to 750. That's how you would specify it. Because 240 is a heck of a lot, heck of a treatment. But if it's BID, then it makes more sense to everybody. So post-op treatment with the trach would be about 4,500, followed by 1,000 to the boost, which would include the stoma. Stoma is basically the hole, right? Would you have a trach tube in? Have you seen anybody with a trach? Do they have a tube in? That's a trach tube, okay. So would you treat them with the trach tube in?
We do, but we're not treating, we're treating up here,
Okay.
a little higher.
So what is the trach tube made of?
It looks like some kind of PVC rubber.
Yeah, it's usually nylon or some such thing. At the beginning, once they had surgery, once they've had a stoma done, they usually put a metal tube in, the trach tube in. And that's to make sure that it keeps it open. It's much more sturdy, as it were. But you cannot treat through the metal. So they either have to have a nylon or some sort of thing put in, or leave it open, or not have a tube in at all. So normally they usually have a tube in for the first 6 to 9 months after they have the stoma. Then they can do without one because it's not gonna close up. So this is a male, female, male. So how is he for talking? Does he talk?
He says 2 or 3 words, and it's normally.
So he holds his trach? Yeah.
Puts his thumb over it, says good morning.
Yeah.
Gets on the table.
Yeah.
Sets up a treat, and
Yeah.
see you tomorrow, and then
Yeah.
walks away.
Off he goes, yeah. So you get used to, if they're talking, you get used to hearing them. They also have what they sometimes call an artificial larynx, an artificial voice box. And they have this little thing that looks like a microphone. Have have you seen that?
They sound
And
like a
they'll hold it.
robot.
Huh?
They sound like a robot.
And they hold it and they talk.
I haven't seen one of those.
Well, they're still there.
Do they have ones with like a button? Because I had a patient who like pressed something and it was similar to that because I've seen somebody
Yeah.
years ago with like the microphone
Yeah.
type thing. But I don't know. He pressed something. He didn't like cover his hole, but he pressed
No,
something.
It's probably an internal one.
Yeah.
The other thing that they can do is learn to use what they call esophageal speech.
Mhm.
And that is actually bringing the breath up from the esophagus and talking. There was a very well-known British actor whose name was Jack Hawkins, and superb actor, 1960s, 70s area. And he basically had carcinoma of the larynx, and he had to have a trach. And he learned how to speak with esophageal speech, and he actually continued to act. And he always had a cravat on so that it covered his stoma. But I wish I could get some video of him because it was very well done. And it's actually interesting to hear him talk. He, of course, has since died several years ago, but anyway, I'll see if I can find some video on him. So that's supraglottic, which is above the glottis. So here is the supraglottic treatment. So you have all of this area. Again, you treat this area. And again, it's going over the spinal cord until about 4,500. And then you pull it back to here so that you're shielding the cord. And then you treat this area. And then we treat the supraclavicular fossa down here. Okay, so you treat the supraclavicular fossa. So this would be 4,500 reduced to what they call off cord, and at the same time, all of this you're also including this supraclavicular fossa because of the nose. Very seldom do we have subglottic tumors. So nasopharynx, one of the most common head and neck treatments. Ethnically, they tend to arise a lot in people from the Far East, China, Hong Kong, Vietnam, Cambodia, that area. So due to rich lymphatic supply in the nasopharynx, the majority of patients present with metastasis to the nose. So we use radiation therapy as a primary treatment for this tumor. Always radiation therapy for primary. 4,500 fields, 4,500 centigrade. Reduced off cord and a further 1,500 are given. Total primary lesion approximately 6,000. I think they've raised it to 7,000 now. So here's the nasopharynx. You notice it goes up to almost, here's the base of the skull, or the base of brain. So it goes up almost to the base of skull. It's close to the EAM, and this is the area we're treating. All the way down, and then here as well. So this part is a junction with this part. And then you have the off cord, of course, at 4,500. And if necessary, you can do electrons back here. With IMRT, of course, now you don't have to do all this stuff. You still have to treat off cord, but all of this can be done in one area or in one arc. But you have to know this stuff first. This is the basics. Oropharynx would be treated slightly the same, would be further down. It'd be more like the supraglottic fields. Nasal cavity. Not many of them, but you can treat them with pose beams, about 7,000. And a vertex beam may be added because you're treating here. Right? Care must be taken to respect tolerances of the optic nerve, pituitary, and brain tissue. Because the nose, right? Where are we treating here? So we're treating the nose. You've got eyes, you've got brain back here, you've got sinuses here. So you have to be extremely careful. Where's your pituitary? It's right there, in the center, where your nose is. Right? So here is, so this is the nose, this is the nasal cavity. So look how far back you're going. This is 100% here. 106% this little doohickey here. So all of this, these are Isidose lines. All of these inside of there is all 100%. This little thing here is 106. So then you've got 90. Here is 72. Here is 54. Here is 36. Here is 18. Here is 36. Look at this. All the way back. What are we going back to? You're hitting the nose. What's back here? Your brain. So you've got 36% of whatever dose you're giving, you're putting into the brain. And notice you've got a 60-degree wedge. That's because of the slopes
Are
here.
they always going to be both wedges always going to be the same on both sides? If the tumor's more on one side than the other, would a wedge be 45
Your
on
wedge
one
may be
side?
slightly different, yeah. Take a turn.
Yeah.
Yeah, well, I didn't want to go while she was gone.
Why not?
I
We
have to
go.
go too, I've been waiting.
I know. Sorry.
We go to different bathrooms.
You can go if you want.
I'm going.
Okay, so yeah, you could, if it was off-centered, you could do a 45-degree wedge on this side. But with it being a nasal cavity, it usually is central. Although one side could be involved and the other side couldn't, so. So here's maxillary antrum and the maxillary sinus. Because it's, what is maxillary sinus? Anatomically, what is it?
It's an open space.
Open space of the face, okay? It's a hole in the bone, basically.
For some of us unlucky people, it's not empty.
Yeah, well, this is the problem. So complete resection is not often possible. So radiation therapy is therefore often recommended post-op and for palliation. Extensive tumors involve the orbit and other sinuses, and can also involve the nose and into the palate. So it can grow down, it can grow lateral, and it can grow superior. So lacrimal gland should be shielded if possible without shielding the tumor, and the dose is usually around 7,000. So here is a fancy treatment of the maxillary sinus. So obviously we're treating this site. So we're just treating this area, but you notice on this particular slide, look at how far down it's going. It's actually going into the mouth. And it's gone up, and it looks as if it's going into, what are the sinuses that are here? Anybody? Sinuses that are between your eyes. Back here. No? Paranasal? No. Ethmoid? You heard of ethmoid sinuses? That's where they are. So, you've got the eye here, and you've got the tumor coming up here, or you've got the lesion coming up here. So it looks as if it is heading into the ethmoid sinuses, and maybe into the orbit as well, slightly. So yeah, and it's actually, this is the area, so it's actually come across, including the nose or the nasal area, the internal nasal area, and it looks as if it's heading into the other maxillary sinus. It can be nasty to treat. So here, the yellow is actually giving 2,500 centigrade. So the whole of this area is getting 2,500 centigrade. The green here and here and here is getting 3,200. And the blue, this part, is getting, 39 something. It's really bad. So salivary glands, most commonly is a parotid. So how do you find the parotid gland? There is a
2.5 cm inferior from the EAM and 2.5 cm.
So from the EAM, you have 2.5 centimeters anterior and 2.5 centimeters in. Whereas, what's the other one? It goes from the EAM. So there's two measurements you can do for the EAM. There's the parotid, which is 2.5 centimeters anterior, 2.5 centimeters inferior. There's another one that's 2.5 centimeters anterior, 2.5 centimeters superior. Which one's that? Pardon? The pituitary, yeah. So you have the parotid, which is inferior, and the pituitary, which is So, surgical removal is best. They go in and they take the parotid. However, if it cannot be excised completely, radiation can be used to sort of mop up.
we opened them and that was it. Like
Mixed photon electron beams are sometimes used, and it's approximately 5,000 in 5 weeks. So here is, take it from me, this is a parotid. It's a rather strange X-ray. This is the parotid gland here. So here you've got 6,004, 5,000, 3,000, 5,000 here, 6,400 here, and then it goes out here. So you're only treating the one parotid gland, you're not doing both, you're only treating one. So what are the symptoms of treatment after the parotid gland? What do they not have, the patients? If you treat a parotid, what do the patients lack? Saliva, yeah. And if they have saliva, it's very thick. And as one of the textbooks says, ropey.
Ew.
Think about that.
What angle am I looking at here? No, I walked.
It's an oblique, it's actually an oblique, that's why I said take it from me, it's a parotid. Yeah. You can see it better here. So here is a parotid, okay? This is a little high for parotid, you should be down here somewhere. So here you have what is called the wedge pair. The patient is lying on their side, so they'll be lying on the bed like that. So the wedge pair will come in like this. Or in this case, they're lying, they're lying on their side. So you would treat 2 wedges this way. Or sometimes you can do one field with a 6 MV photon beam, and then one single field with an electron beam. So the photon field will get the tumor back here, and the electron field will get the tumor back here, closer to the skin.
Yay.
So what I would ask you to do is the next thing.
To study.
Yeah, that too. Look up in your
Chapter 22.
Washington and, pardon?
Chapter 22.
That too. Look up Washington and Lever. Go to the head and neck. And look up to where the head and neck lymphatics are.
Okay.
Okay? So lymphatics for tongue, for mouth, lip, larynx, nasopharynx, nasal cavity, maxillary antrum, and salivary glands. Look up and make sure you know where the lymphatics are,
Got it.
okay?
Yep.